Hello everyone. We're gonna start the general surgery series of lectures, including all the important topics which are important for final year NEET as well as INICET. First, we're gonna start with the breast. The breast will be covered in three parts. Part one will be having the surgical anatomy of the breast, the diagnostic and the brief treatment modalities of the breast tissues and breast lesions. Second part will be having the management of CA breast, and third part will be having detailed discussion about the benign breast lesions. Uh, I'll advise you, if you guys are watching, you can watch in 1.5 to 2x speed. It will save your time a bit. Coming to the surgical anatomy of breast, breast is modified sweat gland. Okay, it's a modified sweat gland. The major extent of it is the major bulk, that the major portion of the breast. It extends from the second to sixth rib and sternum to the anterior axillary fold, and the entire extent of it can extend from the superiorly the clavicle, inferiorly to the eighth rib, and lateral to the latissimus dorsi muscle. The axillary tail of Spence is there in the upper outer quadrant. If it is hypertrophied, can present as a lump. Okay, this picture is very important. This is the pectoralis major muscle. This is pectoralis fascia. From the pectoralis fascia, there are many ligaments of Cooper, right, which are more inferiorly. And if it is involved in any carcinoma of breast, it can cause dimpling or puckering of the breast. Mind it, this is the dimpling and puckering of the breast, not the nipple. And there are 15 to 20 lactiferous ducts in the breast. If those are involved, then they can cause tethering or retraction of the nipples, right? Important thing, that involvement of ligaments of Cooper or the lactiferous duct doesn't change the TNM staging. This doesn't show that the skin is involved or not. The skin involvement is not shown by this. Okay, later we're gonna discuss like some things like Peau d'Orange. Those shows कि skin is involved. That will increase the TNM staging. And retraction of nipple का एक DD है, differential diagnosis. If it is just slit like, it can be underlying duct ectasia. If it is circumferential, it can be malignancy. Okay, coming to the next thing, Peau d'Orange. Peau d'Orange, it is if it is present, it shows that skin is involved, and it will increase the TNM staging of the breast, and it is the most evident sign of breast cancer. However, the Peau d'Orange, if present, doesn't always shows that there is CA breast. It can also be because of underlying mets or a breast abscess. In many years NEET questions you have got, what's the region of Peau d'Orange? It is because of the blockade of subdermal lymphatics. Okay, because of blockade of subdermal lymphatics. This is a PYQ. Come to the lymphatic drainage of the breast. 90% of the breast tissue drains into the axillary group of lymph nodes and 10% to the internal mammary. In the axillary group of lymph nodes, you have lateral, anterior, posterior, which drains into the central, which drains into the apical. Okay, these five group of lymph nodes forms the axillary group of lymph nodes. One more thing, if this is the pectoralis minor muscle, mind it, it's the pectoralis minor. The lymph nodes lateral to it are station 1, beneath it are the station 2, and medial to it are the station 3. More the station, poorer is the prognosis of the CA breast. Okay. Now, rotor group of lymph node is there, which are interpectoral, that is present between the pectoralis major muscle and the pectoralis minor muscle. Now, whenever we get a case of lump of breast, we do a triple assessment of breast, right? First is the history and physical examination. We're gonna discuss each point separately. Second is the radiological, and third is the histopathological examination of the breast lump. Coming to the first one, physical examination. Physical examination is usually done with the pulp of fingers. Okay, remember, it's the pulp of fingers. Okay, and method of examination can be dial, vertical stripe, or horizontal stripe. What does that mean? If this is the breast tissue, suppose, in the dial method, we go from the NAC, nipple areolar complex, and go circularly as a dial. Okay, in vertical stripe, we start like this and we go like this. In the horizontal stripe, we go from medially to laterally, right? This is the best. The dial method is the best method. And how do we report? We report that there is a lump, approx size, at 3 o'clock, suppose. Okay. Second thing, radiological assessments. Radiological assessment as a routine, right? As a routine, details will be there in next few slides. As a routine, less than 40 years we get a USG done, because less than 40 years the breast tissues are dense, and mammography is not effective if the breast tissues are dense. And above 40 years we get a annual mammography done as an assessment or a screening test. Okay, the histopathological examination, FNEC can be there. FNEC is there, but it can't differentiate between invasive and in situ cancer. See, what is the difference between invasive and in situ cancer? If this is the cancer, right, suppose this is the basement membrane. This is the basement membrane. Any tissue will have a basement membrane, right? Now if this is the cancer, so if it is like this only, it is not breaching the basement membrane, then it is a in situ cancer. And if it breaches the basement membrane, then it is an invasive cancer, right? However, FNEC can't rule out the invasive and in situ cancer, because the basement membrane can't be assessed. Also, ER, PR and HER2 status. This is important for the treatment plan of any breast cancer, right? It can be assessed. It can't be assessed through a FNEC. So, the investigation of choice is true cut biopsy or a core needle gun biopsy, which is usually done with a 18 or 8 to 18 gauge needle, best with a 16 gauge needle. The gold standard is always the excisional biopsy. Now, what is the difference between investigation and choice versus gold standard? A gold standard will always yield a positive result if the underlying pathology is there. However, this is not always feasible. Okay. Okay, coming to details of radiological investigation. First is the mammography. It is a contact radiography. Okay, this is the radiation exposed 0.1 to 0.3 CGY, and two views are taken. Medial lateral oblique and craniocaudal, right? This is the medial lateral oblique and craniocaudal. Medial lateral oblique shows most of the breast tissue and also the axilla. Okay, axilla is important to look for any nodes, right? As I said in the previous slide, that it is better for as a screening modality of females more than 40 years of age. However, there is something called tomosynthesis, or like upgraded version of mammography, where the radiation exposure is double, and it can be used for dense breast tissues. This mammography is the best modality of screening for any breast lump, not the self-examination, mind you, because till the time that you will be able to palpate a lump, till that time it will be already a T2 stage of carcinoma, right? So mammography is better than self-examination, and we usually start at 40 years of age, and we do an annual mammography. In mammography, what we see are the calcifications, okay, micro or macro calcifications that we see. The macro calcifications are usually benign lesions. Here are few examples of it. First is the popcorn classification, which is seen in fibroadenoma. Lead pipe or egg cell classification, seen in traumatic or fat necrosis. And two broken needle type is seen. One is in duct ectasia, one is in fibrocystic disease, right? The microcalcifications are suggestive of carcinoma, and in microcalcifications the risk goes like this. Just remember CLSD. Okay, you need to remember this. I can't help. CLSD. If it is in cluster microcalcifications, it shows a more risk of carcinoma of breast, and it goes in this order: cluster, linear, segmental, and diffuse. CLSD. Please remember. However, listen. One very important thing clinically also, that powders. Sometimes what happens, that female applies powder over the breast, and after that, if the mammography is done, it can falsely show that microcalcifications are present. So you need to advise the female ki clean her breast surface before going for any mammography. Okay, clean her breast surface. Coming to the second radiological investigation, that is the USG. Any lump or any mass which is having a solid versus cystic component, like you need to differentiate between solid and cystic component, then USG is the best thing. USG is the radiological investigation of choice in pregnant females and aged less than 40 years. I said because of the dense breast tissue, and also in pregnant females because you can't have much of a radiation exposure. However, the drawback of USG is operator dependent, that from different centers you will get a different size of mass as a reporting. Okay. Third comes the MRI. MRI is investigation of choice in multifocal versus multicentric lumps. What are multifocal versus multicentric lumps? Suppose this is the breast lump having 4 quadrant. A multifocal will be having 2-3 focus mostly in the same quadrant of the breast, and this is the multifocal. Versus the multicentric, it will be having one here, one here. The distance between these two will be more than 5 millimeters, 5 centimeters. Sorry. Okay. Ladies with breast implants, then also the MRI is the investigation of choice. Recurrence after surgery, and MRI is the most sensitive for DCS, ductal carcinoma in situ. In few young high-risk patients, like patients having prior radiation to the chest wall, BRCA mutation, BRCA mutation, right? Our first degree known to have a carcinoma breast, then MRI screening should start at 25 years of age. Otherwise, in normal patients, we can start MRI screening at 35 years of age. Now, 2-3 important things about breast implant rupture. This is just an outside topic. If it ruptures, if it is intracapsularly, then we see a step ladder pattern on USG and a linguini pattern on MRI. Right? How you can remember this? कि ladder घर के अंदर रहता है, तो it is intracapsular. Extracapsular snowstorm घर के बाहर आता है, तो फिर snowstorm is extracapsular. See, any radiological investigation done for a breast lump, may it be mammogram, USG or a MRI, will report the reports will be in BIRAT score. Okay, BIRAT. What does BIRAT stand for? Breast Imaging Reporting and Data System. Okay. Now this is having 6 categories of it. First comes the 0. 0 means the test is inadequate. Means you will have to repeat the test or repeat the sample again. First is negative. Negative matlab there is routine screening. Essentially there is 0% risk of cancer. Negative means there is no breast lump or there is no suspicious of malignancy in this also. Second is for benign breast lesions. Routine screening. This is annual screening. Okay. Annual screening, 0% risk of CA breast. Third, category 3 is probably benign, where there is less than 2% chance of malignancy. Here you need, because there is less than 2% chance of malignancy, you need to have a short interval follow-up, 6 monthly follow-up. These two were for 1 year. This is for 6 months. And 4 you have 4A, 4B and 4C. 4A means low suspicious of malignancy, 2 to 10%, 10 to 50%, and 50 to 95%. Okay, in this you need a true cut biopsy or a FNAC. Tissue diagnosis is important in this. And 5th, highly suggestive of malignancy, more than 95% risk of malignancy. In this also you need a tissue diagnosis. So in these two you need a tissue diagnosis. Okay, and category 6 is for known biopsy proven. Okay, first that biopsy has already been done. It has already been proved that it's a case of CA breast. After that you are doing a radiological investigation, so it comes in category 6. Now coming to the CA breast proper, what are the risk factors of CA breast? Increased age. Any condition that increases the levels of estrogen can result in increased risk of CA breast. Okay, like early menarche or a late menopause. Nulliparity. Obesity. In obesity there is peripheral conversion to estrogen. Okay, these all factors has increased level of estrogens, which increases the risk of CA breast. Family history equal for maternal and paternal side. Okay, this is very important. It is equal for maternal and paternal side. Okay. Hormone replacement therapy, E plus estrogen plus progesterone, it increases the risk. However, low dose OCPs doesn't increase the risk of CA breast. Very important thing to understand. Prior radiation exposure to the chest wall can also increase the risk of CA breast. Maternal age at the first childbirth less than 20 years is a risk factor. More than 30 years is seen as a protective factor of it. Okay. Maternal feeding is also protective if it is done only for 1 year. At least for 1 year. Okay. Coming to the pathology, 90% of them are sporadic, 10% is familial. Most common gene mutated is TP53. Okay. And most common gene in familial thing is BRCA1. Okay, coming to BRCA1 and BRCA2. BRCA1 is in 17q, chromosome 17q, BRCA2 in 13q. Female breast cancer, this has increased risk, this has less risk. It is like in female breast cancer, BRCA1 mutation is more commonly seen. Also in cases of ovarian cancers, BRCA1 is more seen than the BRCA2. However, in males with breast cancer, prostate cancer, and pancreatic cancer, BRCA2 mutation is seen mostly. Okay. Coming to BRCA mutation, if there is a female candidate with BRCA mutation, it is called HBOC syndrome. HBOC stands for hereditary breast ovarian cancer syndrome. Okay, hereditary breast ovarian cancer syndrome. If it first degree relatives are screened for MRI, I told you high risk patients MRI will be done at age 25 years. And if BRCA mutation is present, first thing that we need to counsel the female is ki lifestyle changes, weight reduction, smoking and alcohol cessation, right? And there is a SERM, right? These are the pharmacological agents like tamoxifen, which can reduce the risk of cancer by 47%. Coming to the histological types of CA breast, the malignancy can arise from the ducts or the lobules. If it is from the ducts, it's invasive ductal carcinoma, or it can be the invasive lobular carcinoma. Now you have to remember one gene mutation, E cadherin mutation. There is a C, तो just remember D है तो C नहीं होगा. Okay. So in the invasive lobular carcinoma, E cadherin mutation is present. In ductal carcinoma, E cadherin mutation is absent. One important thing, कि E cadherin mutation is also seen in diffuse gastric cancer. Okay, one extra point. Based on the immunohistochemistry, we need to check the status of ER, PR, and HER2/neu. This is the estrogen receptor, progesterone receptor, and the HER2/neu receptors. Okay, the ER, PR base it's scored from 0 to 8. The scoring system is called the Aldred score, and we all know that estrogen and progesterone receptors are present in the nucleus. Then hence the nucleus will be stained. Okay, compared to ER and PR, HER2/neu, the membrane will be stained. It's not the nucleus, it's the membrane that is going to be stained. And HER2/neu scoring is given as 0, +1, +2, and +3. 0 is and +1 is negative. Both of them are negative. This is quite different from other grading system. 0 and +1 here is negative. 2V is equivocal, for which FISH is done. FISH is done, it amplifies the gene, and after that it shows a positive or a negative report. And +3 is a positive. And if HER2/neu is positive, then during the chemo regime we add trastuzumab or a Herceptin. And Ki67 is one thing that shows the proliferation, that how fast the tumor is progressing, how fast the cells are multiplying. Coming to the molecular classification of CA breast, in this we're gonna check for the ER, we're gonna check for the PR, HER2/neu, and Ki67. Okay, the first is the luminal A, where ER it is positive for ER and PR, negative for HER2/neu, and Ki67 is negative. This is the most common subtype, and this is having the best prognosis. Okay, coming to luminal B. Luminal B mostly it is having ER positive, PR positive, HER2/neu is also positive, and Ki67 is low or high. It can be low or it can be high. This negative means it's low. Okay, low proliferation. Luminal B mostly is this, but sometimes it can be ER positive, PR positive, negative for HER2/neu, and Ki67 can be high. TNBC, triple negative breast cancer, negative for all three with a high Ki67. Okay, and one is called HER2/neu enriched. Which is negative for ER, PR, only HER2/neu is present, and it can be high or low. Right. Now one thing, this TNBC is having the worst prognosis, and here it is positive for cytokeratin 5,6. Okay, versus there is one more type subtype, that is Claudin law, that is also negative for ER, PR, HER2/neu, negative, but negative for cytokeratin also. Okay, coming to the TNM staging of CA breast, important things to remember, that investigation of choice for CA breast is true cut biopsy. Okay, investigation of choice for TNM staging, then it becomes the PET-CT. See, for N and M stages of TNM setting, that is the nodes and metastasis status, you need to look at the PET-CT and look for any nodes or other organ involvement, okay? Then it becomes the PET-CT, and screening of choice is mammography. Okay, coming to the T staging, T0 means there is no tumor, T1 means till 2 centimeter, T2 means 2 to 5 centimeter, T3 is more than 5 centimeter, and T4 implies for extension to the chest wall, skin or ulceration. Okay, there is something called TIS. TIS means tumor in situ. I already told you how to differentiate between in situ and an invasive carcinoma. In TIS, DCIS and Paget's disease is there. Remember, LCIS, lobular carcinoma in situ, is a benign condition. It is not included in the TNM staging. Now coming to T4, T4 can be T4A, T4B, T4C and T4D. A means the chest wall is involvement. B means skin. C means chest wall and the skin both are involved. D is inflammatory. How do you identify inflammatory? More than 1/3 of the breast tissue will be having peau d'orange. Okay, this carries the worst prognosis. Fine. In the chest wall, remember, pectoralis major and pectoralis minor is not included. Okay, only ribs, intercostal muscles and serratus anterior. If it is involved in CA breast, then only we say that chest wall is involved. Similarly, in the skin, peau d'orange, ulceration, and satellite nodules. Only these three are involved as a sign of skin involvement. Other things like the dimpling, puckering of skin, and retraction of the nipples are not included as signs of skin involvement. Coming to the N staging, you need to remember that till N2A we are only talking about the axillary lymph node. N0 means there is no lymph node. N1 mobile axillary lymph node. N2 there is N2A and N2B. N2A is fixed or matted axillary. Till N2A we just talked about axillary group of lymph nodes. N2B stands for internal mammary involvement and axillary is negative. In N3A, just remember N3A and N3C. N3A नीचे वाला तो infraclavicular, A नीचे आता है, फिर C आता है, बीच में B आता है. N3C is supraclavicular and B stands for the second alphabet. 2 मतलब दोनों involvement, internal mammary plus axillary. Coming to the M staging can be M0 or it can be M1. M0 means there is no distant mets. Mets are present. What is the most common site of mets? It's the vertebral bones. In the vertebral bones, the lumbar vertebra are the most common sites of mets. Why the lumbar vertebra? Lumbar vertebra because it is more prone for wear and tear. If anything is more, आप लोग को समझना पड़ेगा कि if anything is more prone for wear and tear, it will provide a surface for seeding of those mats. Okay, that's why these are most commonly involved. And also this vertebral are having a Batson plexus of valveless veins. Okay, that's why these commonly seeds into the vertebral bones. And the type of lesions are osteolytic more than osteoblastic. Same thing goes in prostate carcinoma also, but in that it is osteoblastic more than osteolytic. Okay, now coming to in the TNM staging, there can be few prefixes. Okay, for example, for C it stands for clinical, P for pathological, R for recurrent, M for multiple, Y for important one. Y is after a neoadjuvant chemo. What is the meaning of neoadjuvant? Anything that is given prior surgery. Okay, like if you are planning for surgery and you just want to reduce the size of it, you give a chemo, then do a surgery, then again give chemo. So this cycle of chemo is called a neoadjuvant chemo. C means like see you later wala. This is autopsy. Like someone died of it and after that you are doing TNM staging, then C is there, the prefix C will be added to it.